Hello guys, today we'll be discussing a topic of trauma, that is maxillofacial trauma along with neck trauma and spine trauma, and we are in the NEET PG surgery series. So where last class we had discussed about head injuries and head trauma, and now we'll be discussing about face and neck injuries. So without further delay, let's get started. And before starting, I would like to thank and pray the teachers, parents, and God for giving us the opportunity and support. So that we can work and do our duty. So without further delay, let's get started. So maxillofacial injuries are classified, rather these are injuries of the mid-face region involving the maxillary bone and the sphenoid bones, and they are classified on the basis of Le-Fort fracture, which is divided into three types, which we'll see in detail. And these fractures are due to direct trauma on the face due to rapid car change in speed and or baseball injury or bat injury on the face. So due to these it is caused, and it results in separation of facial bones partially or completely in the mid face region. So we'll see the types based on the classification, that is Le-Fort. So Le-Fort 1 is the lower one, we can see in the diagram. It is at the level of alveolar ridge. So it is horizontal at the level of alveolar ridge. Then we have type 2, that is like a pyramid, as we can see in the nasofrontal region or frontonasal region, frontonasal suture. So this is type 2. And then type 3 is at the level of orbits. So it is craniofacial dislocation at the level of orbits. So there will be some symptoms, but generally they overlap most of the time. These injuries overlap most of the time. And if it is very specific, then there could be some specific symptoms, like if it is type 1 injury, there could be swelling in the upper lip, buccal bruising, and difficulty in closing that mouth, that is malocclusion, loosening of teeth. In case of alveolar ridge, that is type 1 maxillofacial Le-Fort fracture. In type 2, there will be deformity of the upper part, that is mid face, and swelling in that region, mobility of upper jaw and nose, malocclusion again, some periorbital edema, ecchymosis, swelling in the periorbital region. Epistaxis could be there because it is nose. Then bruising of the vestibule, bruising and vestibule plate bruising, this could be there. And sometimes rhinorrhea, that is CSF rhinorrhea. CSF might be coming out from the nose. So this is type 2. And in type 3, that is the upper one, which is horizontal orbital region, that is craniofacial dislocation. In that, the symptoms are similar to second one. Apart from that, there will be lengthening and flattening of face, orbital hooding, enophthalmitis, mastoid bruising, and ear drainage and hemotympanum. So even ear will be affected. Now coming to next, that is what will be the investigation of choice for these issues, these injuries. That is, we will go for non-contrast CT of the face mainly. Apart from that, if we are suspecting other injuries or needed, we can better go for CT head, that will include the face, and CT neck or CT neck, up to including CT neck. So it will give us a better picture. So CT head neck will give us a full picture. Otherwise, we can also do CT face. And if it is asked, if you have to ask in one word, then it is NCCT face. And if there is any such injury, then the treatment will be by surgery, that is open reduction and internal fixation, which is here we fix with plates metal plates which are placed, metal plates and screws from which we fix the bones. So with fixation along the main facial buttress, which are like a four legs of a stool. And what are these four legs? You can see in this diagram, it is given in very beautifully from the Bailey. So this is the zygomatic arch, this is the zygomatic process, this is the infraorbital ridge, infraorbital line, and this is the maxillary bar, maxillary process or bar, we can say. So these are the four legs of the stool which will be used for fixing the plates with the screws to give support to these injuries. Okay, so these are the four legs of the stool. So this was all about maxillary facial fractures, Lefort fracture, and something about its management. Now we'll be just going through some principle of facial wound suturing. So very common thing that if there is injury, we'll first clean it, debride if there is any contamination, foreign body, remove that, and then we can take things ahead from there. Then in case of cosmesis, we have to take care of the landmarks like the vermilion border of lips, eyelids, and the nose. So those have to be taken care of while suturing, and it should be done with fine sutures, like it can be used like 2-0 nylon, and better it would be non-absorbable suture on the face. And if it is in the mucosa, we can take absorbable suture like catgut or vicryl, and suture should be removed within 5 days. And in case of intraoral laceration, we have to be careful, and that we have to assess the depth and then decide how we have to suture it so that the wound does not give way and goes into wound dehiscence. Then we have talked about the suture we will use for intraoral cases. We'll use absorbable suture. Then facial nerve laceration, that can be repaired primarily, because that is important because it may affect the neurological function, the sensory function of the face. Then coming to parotid duct, if that is injured, then it will be cannulated over a stent and is to be anastomosed. So it will be cannulated within the mouth and anastomosed over a stent. Then we'll also give antibiotic so that the infection does not occur. And we'll also have a anaerobic cover, that is metronidazole, gram positive and anaerobic, that is amoxicillin and metro. And to reduce facial edema, we'll go for steroid, that is dexamethasone. So facial edema, swelling in the face, traumatic swelling, for traumatic swelling, dexamethasone is used for facial edema in case of trauma. So this was all about maxillofacial injury and face injuries. Now we'll be seeing the topic of neck injuries. So neck injuries are very important because these have high mortality rate and can cause sudden death, very quick death in case when there is injury to the very vital organ. Then we have in these neck region, we have three region, that is zone 1 to zone 3, as you can see in this diagram. Zone 1 is the lower part starting from the sternal notch up to the cricoid cartilage. Then from zone cricoid cartilage to the angle of mandible, it is zone 2, and above that up to the base of skull, it is zone 3, as we can see in the diagram. From the thoracic inlet, that is sternal notch, to the cricoid cartilage, the structure especially here will be large vessels and trachea and esophagus, so we have to be careful while we are considering injuries in these regions. Then cricoid cartilage to angle of mouth, that is second one, where there is most surgically open area, that is the carotid, vertebral arteries and the jugular veins. Then lastly is third one, between the angle of mandible and base of skull, which it is a difficult surgical access and has vital structures, the nerves, muscles and the vessels. So how do we manage these patients? So in case of unstable patient, we have to immediately take the patient to the OT and evaluate by exploration and repair. In case of stable patient, we can go for selective diagnostic procedures like CT angiography, duplex ultrasound, and even we may need some scopies, which we'll discuss, like bronchoscopy, esophagoscopy, in this manner. Okay. Now coming to blunt neck injuries. In laryngotracheal fractures, esophageal rupture, and cerebrovascular injuries, these complications can occur in case of blunt neck injury. So we have to be careful regarding this. And now we'll be seeing the blunt cerebrovascular injury. We had discussed in slight detail it yesterday. Now we'll be going through it with some more detail regarding that. So cerebrovascular injuries are not very easily visible but can be occult, so hidden. So if not diagnosed timely, अगर सही टाइम पे नहीं देख रहे हैं तो it can cause cerebral ischemia, infarction and death. तो पेशेंट का ब्रेन में ब्लड जाना रुक के पेशेंट का डेथ हो सकता है. So which patients are for high risk for this issue as given by Denver's criteria? If patient is having these sign symptoms like expanding neck hematoma, खून जमा हो रहा है, arterial hemorrhage in neck, nose and mouth, then focal neurological deficit, कोई हाथ पैर कोई एरिया काम नहीं कर रहा है, stroke can be seen from in the form of CT or MRI, that is a possibility, and neurological deficit unexplained by CT. So if any of these features are there, then we have to consider for BCVI, that is brain cerebrovascular, blunt cerebrovascular injuries. Then coming to risk factor, what are the risk factor for these issues? So mid-face injury again, which we have seen, then basilar skull fracture involving the carotid canal, then diffuse axonal injury with GCS less than 6, which we had seen yesterday. Significant cervical spine fracture or injury will result into that. Then significant soft tissue injury in the neck, such as seatbelt mark, and near hanging with anoxia. So hanging, severe neck injury, spine fracture, cervical spine fracture, low GCS, diffuse axonal injury, DAI, and base of skull fracture and mid-face fracture. So these can be the risk factors for this blunt cerebrovascular injury. And how do we evaluate this patient? As we had seen yesterday, it is CT angiography or a digital subtraction, which is more precise. And on this, how is it classified? So if it is grade 1, again it is Denver's grading for BCVI. So in grade 1, the luminal irregularity will be less than 25%. So lumen will be irregular in less than 25 area. Then in grade 2, there will be dissection of hematoma with more than 25% of narrowing. So in 1 it is less than 25, more in 2 it is more than 25. In 3 there will be pseudoaneurysm. In 4 there will be occlusion of the vessel, and in 5 there will be transaction and extravasation of blood. So how do we manage these? As we had seen yesterday, for the most severe, that is grade 5, either it is surgery or endovascular therapy, and mostly it is needed, it cannot be avoided. Then in other grades, it can even be managed by medical management, that is antithrombotic therapy, heparin and all, antiplatelet, and should be initiated with the partial thromboplastin time maintained at 40 to 50 seconds. And after 7 days, we repeat the angiogram. If everything is okay and healing, then we can discontinue the medication. And if there is some injury, we'll continue medication for 3 months. And if needed, we'll consider endovascular therapy. As we have seen this yesterday, the chart. So this is all about the flowchart of this BCVI. So how do we go ahead for this? So in CT, if you are finding something positive, then we'll go. In grade 5, we'll manage by operative or endovascular treatment. In grade 2 to grade 4, we'll consider the situation whether we have to go for surgical or medical management. And in grade 1, we'll definitely go for antithrombotic with heparin or antiplatelet therapy. And again, repeat CT angio and decide further whether we need to stop treatment or continue treatment, or there is some need for any intervention in the form of endovascular therapy. Now coming to management of other neck injuries. So first and foremost, if there is no bleeding, we'll secure the airway by immediate intubation, because sometimes even this can fail and we may need a tracheostomy, because tracheostomy is the surgical airway of choice in case of upper airway injury. So even that may be needed. And again, hemorrhage that we have discussed, it can be stopped by digital pressure or resuscitation until patient is taken to the operating room. So if we are finding the patient is bleeding, the resuscitation should start immediately in the form of IV fluids, crystalloids, and if it is possible, we should apply digital pressure or compression so that the bleeding can be minimized. Then exploration, that should be immediate in case of unstable patient. अगर bleeding है, BP ठीक नहीं है, तो तुरंत ऑपरेशन के लिए लेना है. In case of stable patient, we can do some imaging, esophagogram, bronchoscopy and all that to rule out some details of the injury, like the vascular injury, aerodigestive tract, like trachea, bronchus, or even esophagus, whether there is injury regarding that. And then in zone 2, even in stable patient, exploration should be undertaken. Okay, when should we do that? When there is expanding hematoma, enlarging hematoma, बढ़ते जा रहा है, then, or we are suspecting a airway compromise due to injury. So in these two cases, we have to consider that we have to go for exploration. Then anterior, considering how do we manage these things, these injuries, some techniques regarding that. So incision is given along the anterior border of the sternocleidomastoid. We identify the vein, arteries, trachea, esophagus, and we start managing them. So in case of IJV injury, we mostly go for direct repair. If that is not possible, then we can go for ligation. Facial vein, if that is injured, then we go for ligation. Carotid artery, if there is small injury, then it can be repaired by simple closure or end-to-end anastomosis. If there is major injury, that is internal carotid artery getting injured, then we need a graft, that is transposition graft from the external carotid artery. Then coming to trachea, if it is a small wound, we can directly close it with absorbable sutures. In case of large wound, we'll require resection and anastomosis. And in case of anterior wounds, it can be brought out as tracheostomy if required. So this is how we manage trachea. In case of esophagus, small wound, again we'll close in 1 or 2 layers after cleaning it and debridement. And in case of large wound, we need some form of diversion, that is esophagostomy, so that we can manage the wound temporarily and later do definitive anastomosis. So this is the flow chart for neck injury, especially the penetrating neck trauma. So if there is any hard signs of arterial injury or hemodynamic instability, like loss of consciousness or something like that, then if we have if this injury is there, then we will secure airway, direct pressure, take the patient to OR for exploring. So if this is unstable, then we will directly take the patient to OT by securing airway, compressing the bleeding, and go ahead. If there is no such sign, then if we are suspecting an injury, then we'll go for location of the injury. We'll try to define where the injury is. If it is in zone 1, then we go for a CT neck. If that is positive, then again we go for exploration with or without endoscopy, bronchoscopy, and if required, even angioembolization, which is an interventional radiological procedure, where we'll be securing the vessels by interventional radiology by minimal invasive technique. And if the CT and neck angio is negative, then we'll consider other thing. Before that, if the injury is of zone 2 and if symptoms are present according to that, if there is no symptom, then we'll again go for CT angio. If there is symptom, then we'll directly go for neck exploration. So if in zone 2 there is injury with symptoms like expanding hematoma and all, then we can directly take the patient to the OR operation for clearing the pathway, that is neck exploration. Then if CT angio is negative in both the cases, then we can concern about thoracoesophageal injury and we can consider esophagoscopy, bronchoscopy and esophagography for further delineation of the anatomy and injury. Then coming to if it is zone 3, then we'll again go for CT angio, and if it is positive, then we'll go for again neck exploration surgery and angioembolization or upper hypopharyngeal endoscopy, that is hypopharyngeal endoscopy. So this was about penetrating neck trauma. How do we manage these? Now coming to spinal trauma. So before starting spinal trauma, we'll understand the stability part of spine. So in spine, we have a 3-column model of stability, which was given by Dennis. So Dennis 3-column concept of stability. So here we have the anterior column, which is the part which includes the anterior part of the vertebral bodies. Then the middle column, this is the middle column which includes the posterior part of the vertebral body and some part of the posterior segment, posterior elements, and rest posterior column is completely the rest of the posterior elements of the vertebra, the transverse process, the spinous process and all that. So what does this concept say? That if two or more columns of this uh, three columns, two or more columns among these 3 columns are injured, then the spine becomes unstable. Okay, so if any two, like anterior two or anterior and posterior, or posterior two, middle and posterior, these two are injured, then the spine becomes unstable. And the stability, 80% stability is gone by the anterior and the middle column, and posterior 20% stability is through the posterior column. So as per this, it will help us in assessment of spine injuries. Now coming to causes, most common cause being RTA, fall from height, and violence or assault. Then how are the types of injury? It could be bony injury or it could be a neurological injury, that is spinal injury. And important topic which we should know, that is spinal shock in this, which is temporary physiological disorganization of the function of the cord. So spinal cord's function is temporarily affected and it can occur within minutes of injury and can persist up to 6 weeks and sometimes even more if the damage is more. And how is the clinical manifestation? So there will be paralysis, that is loss of muscle function, hypotonia, decreased muscle tone, hyporeflexia, decreased muscle reflexes, and these generally resolute by 6 weeks. And which reflux comes first? That is bulbocavernous reflux, which is the first to return. Then coming to initial management, how do we manage? Again, it is same. If there is any bleeding, we'll stop that. After that, we'll go for airway breathing and circulation that we have discussed already. Then the next 3 concepts are very important when considering neck and spine injuries. That is immobilization, and that will be done by a hard board, that is spine board, and rigid cervical collar, that is the Philadelphia collar, which will be protecting the neck. And we'll have to transport the patient very carefully with help of log roll, which will at least take 3 to 4 people, ideally 4 people. That spinal log roll will needing 4 people. Then we have to take care that while removing helmet, there should be at least 2 people who are involved in removing the helmet, as we have discussed it. And in case we are suspecting there is hypotension, low pulse, low volume pulse, we'll start with IV fluids ASAP, and we'll also elevate the lower limbs so that the most of the blood can come to the upper part. Then we'll secure in airway again the nasotracheal intubation or orotracheal intubation. If that is not possible, we'll go for tracheostomy. Then we'll also check for perianal tone and anal sphincter in checking. That will give us idea whether the spinal injury is complete or incomplete. And in the clinical features, we'll check for the external injury, which will give us the mechanism or how the trauma has occurred. In the spinal examination, we'll check for the deformity, gap, and tenderness, or there is some elevation, that is step. So all these things can be examined and found out. In case of neurological examination, we'll check for the respiratory paralysis. If that is there, the patient will need ventilatory support. Whether there is any weakness or complete weakness, that is paralysis and paraplegia, paralysis or plagia, that is hemiplegia, paraplegia or quadriplegia. Refluxes, which could be areflexia initially and later hyperreflexia, and even sometimes lack of reflexes, that is areflexia again. And sensory level, that has to be confirmed, and this is assessed with help of, we'll discuss that also, autonomic bowel bladder disturbances, that has to be checked. And if there is any spinal syndrome due to this damage, which could be either anterior cord syndrome, posterior cord syndrome, central cord syndrome, Brown-Sequard syndrome, or complete or incomplete spinal transaction. And the criteria which we use is the ASIA criteria, that is Asia Spinal, American Spinal Association criteria, ASIA criteria, American Society of International, uh, American Spinal International Association classification criteria, that will help us in grading these injury. Now coming to imaging. So initially we can go for X-ray spine, that is lateral X-rays, lateral and anteroposterior spinal X-rays, and but the investigation of choice will be NCCT for this bony element mainly. Bone and soft tissue will be delineated better in the CT, and we'll come to know whether there is cord compression or not by the myelography. And for the cord, spinal cord injury and cord edema, which if indicated in case when there is functional neurological deficit, we go for a MRI spine. In that, we can go for some specific MRI of some region and screening of the rest of the region. Like for example, if the neck injury is there, we can go for MRI of the cervical spine and screening of the whole spine. Similarly with the CT also, we can go ahead with that. Then coming to treatment, again we'll protect ABC, start the initial aspects. Then neuroprotection, which is generally not needed nowadays. Earlier we used to give steroids in case of these trauma patients of the spine and head injury, but now it is not recommended. Then coming to surgery, if there is having neurological deficit, spinal injury is having neurological deficit, then we will have to consider, depending on the severity, whether we have to go for surgery and decompress, that is pressing the spinal elements, spinal cord. So decompression by opening and realignment of the malaligned or disaligned spine, realignment, and then stabilization of the spine. And this is done with help of internal fixation, that is open reduction and internal fixation with help of various plates and screws, rods, plates and screw, or orthotic devices, even that can be used for stabilization. Then we'll have rehabilitation in the form of physiotherapy and orthotic support and occupational support. Complications which have to be addressed, that could be a progressive neurological deficit. So this was basics about spinal trauma. And this, in this image we can see how it is fixed with this cage, screws and rod, the spinal injury. As you can see here, you can see the compression and causing indentation in the spinal cord, and this is fixed with help of a cage, metallic cage, the vertebral bodies are supported with this metallic cage by the anterior cervical surgery approach, and by the posterior approach we have fixed the posterior part of the spine, posterior approach with the rods and the screws. So this was all about spinal trauma. Hope it has been understood, and if you have any doubts or anything, you can let me know in the comment. And if you have liked the video, please like, share and subscribe to my channel, and keep studying, keep growing, because great things take time, and never give up. And see you soon in next video. Thank you for watching. Thank you.